We've got 15 minutes for discussion. We'll start with questions. Speak loud. If you're not loud enough, I will repeat the question and toss the mic to the appropriate person to answer it. So we've got a choice. We've got IVUS, IFR, FFR. When do you choose which modality?
That's a great question. Thank you for bringing it up. It gives me extra 2 minutes to talk about it.
You have 10 seconds to answer.
Between IVUS and FFR, like I mentioned, IVUS and FFR are very well validated for left main stenosis. There's a lot of data. Lumen area measurement for IVUS will be sufficient if you made less than 6 millimeter. If the lumen area was for left main lesion was more than 6 millimeter, then you would want to look at FFR to complement your IVUS data. So that's for the left main data. If you have IFR, IFR is, at this time, with the current situation, IFR is validated for, in the two studies that are published last year, and it's been compared to FFR values. It has a different threshold, 0.89, less or above. Less is significant, more is not significant. It depends on which wire you have. In our lab, we have FFR wire. We don't have the IFR technologies. If you happen to have IFR technology in your lab, you may be able to use that because there is a correlation between FFR and IFR with slightly different thresholds. FFR threshold being 0.80, IFR being 0.89. For non-left main stenosis, IVUS, if the lumen area is more than 4, you're more than confident that it's going to be hemodynamically insignificant, even if it's in a proximal vessel, non-left main stenosis. But if lumen area, there's a lot of lumen area that have been put out in the data, all the way from 2 to 4, based on different studies, and there's a lot of discussion. It truly depends on how big the reference vessel is, true vessel is, how large of a myocardium it supplies, and which vessel you're looking at, proximality, midality, distality. So it's hard to define a lumen area based on IVUS being hemodynamically significant. So if you if you happen to do an IVUS first because you were planning to size the vessel and you found a lumen area that's 4 millimeters or more, you can leave that considering that this most likely is hemodynamically insignificant. But if lumen area was less than 4, then you may want to consider FFR or IFR on top of that. So in our practice, we use a lot of IVUS and FFR, a lot. I mean, we are to the point where administration is after us asking us to use less because obviously it adds cost to the procedure. I mean, but we think it really helps us in a lot of cases to optimize the stent, size the stent properly, and which has been shown significantly in IVUS data that stent optimization, especially when we use long stents, more than 28 millimeter stents. And there's a significant amount of data that it reduces the clinical outcomes, especially in terms of reducing the in-stem restenosis and downstream interventions. So I think you look at the clinical situation. I mean, if you happen to have a patient where you know there's a very tight stenosis, you don't need to do an FFR on that, okay? But if you happen to have a large vessel where you're not sure if this vessel is 3 millimeters or 4 millimeters, I mean, even after 8 years of practice, I still have a hard time sizing the exact size of the vessel. On IVUS, you end up most of the time finding the true size, which is much bigger than you expected. So I think the technology you have to use, you cannot use in every case IFR and IVUS together because it may be too much for the cost of the procedure. But based on what you want to optimize, if you're looking for left main, I will go with the IVUS. Take IVUS first. If it was non-left main stenosis, I will go with an FFR first for hemodynamic significance. But for stent optimization, IVUS has definitely much better data.
Great. Really loud.
Let me give you the
Post-PCI FFR. They do that in their lab. Okay. FFR or IFR? Okay, so you stop, mix more adenosine, and administer it. IV or IC? Okay. So that means you guys are patient. Okay.
Another great question. It requires time, patience, like Dr. Kleiman mentioned, and So we used to do that in our lab also. There's obviously data, and ideally if you have a type A lesion, type A or type B lesion, focal to short lesion, no downstream disease, you expect the FFR, after stenting, you have resolved the whole vessel conductance. And your FFR should come close to 1. And if you can demonstrate that, you will have a great result. You've really confirmed your stent optimization. But I can tell you over time, we've learned that you rarely come across lesion with the FFR is going to come back to 1. And there is data that the FFR with drug-coated stent is more than 0.9 at post-stenting. It's recurrent events are less compared to if you're left with an FFR of 0.84 or 0.85. So, and it makes sense. I mean, I think that is just a marker that you have diffuse disease, and unfortunately your stent is within, from not normal to normal vessel, is within from disease vessel to disease vessel, which nowadays is the true reality. For all PCIs, you end up having to find the stent placement from a disease segment to disease segment, treating the most severe stenosis, and the rest of the disease is treated medically. So I agree. I mean, I think if you have time, patience, and the data supports it, and it also makes sense, the lower your FFR post-PCI, the better the result. And the cutoff is usually around 0.9.
So let's go to live streaming. Susan, got something for us? No. Are you sure? Okay. Another question. Sir.
For patients presenting with STEMI and we're deciding on access, radial versus femoral, and based on the trial that radial is better, are there any markers or anything that you see on EKG or on vitals that would make you start with femoral right away, or you would still rather go with radial and then switch to femoral if needed?
Okay, so let me ask you a question. Which trial?
I think they presented one here saying that matrix, and I think the other one.
So there are there are 3 trials: Rival, Rifle, and Matrix.
Okay.
The one that put the ball out of the park was Matrix.
Mm-hmm.
That was the last of the 3. And there's a very important point. In the Matrix trial, which showed the greatest benefit, you had to be a good radial operator. So you had to have completed at least 70 PCIs with the radial approach, more than in Rifle or Rival. So there's some criteria. So much of this depends on how good you are at radial puncture. So for the younger generation, it's going to be easier because you'll be doing more radial caths. For us older guys, you've got to have the confidence to say, okay, I'm going to be able to get this quickly by radial. And for most of us, that means setting a timer. And when you hit 5 minutes, if you haven't hit the coronary, it's time to puncture the leg. So you prep both at once. Part B of your question, are there any things in vitals that you would look at? And the answer is yes. If the patient is hemodynamically unstable, you'll want to think about support devices. That means femoral. So when you look at series retrospectively of where survival is better, it's going to be better for radial because hemodynamically unstable patients go to femoral access.
Okay, thank you.
Another question.
What's your take on OCT? Was not mentioned yet.
Okay, OCT. Well, Syed, yes, you get 10 seconds here.
It depends on what technology you have. Okay, the benefit of IVUS is that no contrast, plug and use. I mean, with the kind of IVUS that we have is phased array, it takes like 10 seconds to get it going. Okay, for optical coherence tomography, the resolution is about 8 to 10 microns, much better resolution. You do have to use contrast. You do have to connect console, get it all ready. And in labs, if you're used to using it, if this is what the technology is used for coronary imaging, you'll get really good at it and get it really well. So it really depends on what you have in your lab. And there's good correlation between IVUS and OCT. There are studies that have shown that the IVUS tends to overestimate and compared to QCA versus OCT is more closer to that measurement. So the actual MLA will be slightly different. So the MLA data that I presented, the 6 millimeter square, I would not use that for the OCT-derived measurements. And so the OCT data is different, but it has a much higher quality imaging for you, for stent optimization, plaque characterization to some extent, and lesion assessment. Your OCT imaging will be much crisper and clearer, but it requires contrast preparation, and obviously it's another expensive catheter.
We had another question. Okay.
So it's always been counterintuitive for me why a drug-eluting stent would require additional length and
Additional?
additional duration and the way
Okay.
Can we kind of touch on the pathophysiology for the restenosis as well as its relationship to the duration of drug-eluting?
Okay, Sanjay, this one's for you. Why would the duration of antiplatelet therapy be longer for a DES than a bare metal stent? You have 1 minute. It takes 30 minutes to answer that question, but try and do it in one. It's the opposite of time dilation.
There you go. Well, so you have a bare metal stent, which is, as the name suggests, bare metal. So the main issue is neointimal proliferation and smooth muscle formation inside the stent, not so much acute stent thrombosis. Now you have a drug-eluting stent, which has a PTFE coating that is a reservoir for a drug. And if that is exposed to which is inside your artery, which is exposed to your system, you have a higher chance of stent thrombosis. Hence, you need a longer dilution time till all the cells have been covered by your endothelium. Does that make sense?
Question from the back.
Is there any data supporting like high-grade left vein disease and balloon pump while they're waiting for CABG?
Short answer. Question, data supporting use of balloon pump in patients with high-grade left main disease while waiting for CABG. Or waiting for PCI. This is 2018. Mahesh, this is for you. Are there any data to support that practice? So let's assume this is a patient who's hemodynamically okay without persistent angina. Patient who's having pain after you've made the diagnosis, yes or no? Admitted with unstable angina, cath, okay at the time of cath? Okay.
If there's no evidence of ongoing ischemia, either symptomatically or otherwise, then and you've got a stable patient, then I don't think there's any benefit in using a balloon pump.
And that's an excellent question. In my training, sometimes patients coming in with unstable angina, acute coronary syndrome, initial stabilization, going to the cath lab, have significant multivessel disease or significant left main disease. I saw my mentors and my teachers put in a prophylactic intra-aortic balloon pump, consult cardiovascular surgery, send the patient to the coronary care unit, and then the same day, get their surgical revascularization done. So there is this sense of added security with placing an intra-aortic balloon pump with the theoretical advantages of increasing coronary diastolic perfusion pressure with significant left main and multivessel coronary artery disease. Do we have data, randomized data that shows prophylactic use of intra-aortic balloon pump insertion prior to revascularization? No, so we don't have it. And then it just individualization of therapy, patient still having EKG changes, dynamic EKG changes, chest discomfort, still in the acute setting and while you're waiting, then that's a judgment call, but there's not a routine usage, and I'd be happy to hear your experience as well.
Yeah, mostly it's a waste of time that puts patients at increased risk for balloon pump complications, particularly when you look at balloon pump data in other settings, which is really minimal to nil. Susan, do we have anyone live streaming yet? Okay. I guess we didn't draw the remote audience we'd hoped on. Do we have time, or are we out? Okay. Okay, guys, I hope you enjoyed this session. I hope you learned some basic foundations. Go have a break, have a coffee, and visit the exhibits.